So everybody now knows that RUBY trial, the ENGOT-EN6 trial, which was presented half a year ago, published in New England Journal, have already in the dMMR population received label in FDA and positive opinion by European Medicines Agency. So we will have it soon in Europe as well. That trial was done, that was a randomized double-blind trial done in stage 3, stage 4 and first relapse endometrial cancer patients. We took the rare tumors as well, like carcinosarcomas, and patients were stratified according to their MMR status, according to the previous use of radiation therapy, and according to the stage of the disease. And they were one-to-one randomized to receive carboplatin-paclitaxel and Dostarlimab or placebo for 6 cycles, and then continued on monotherapy up to 3 with Dostarlimab or placebo for 3 years, or up to 3 years. The primary endpoints of this study were multiple. It was progression-free survival for the dMMR population, progression-free survival for intention to treat population, and overall survival for intention to treat population. And we have seen a really unprecedented positive effect in the dMMR population with a hazard ratio of 0.28. We have seen a clear benefit in intention to treat population with a hazard ratio of 0.64, both for PFS and for OS. OS data is not mature yet because there were not enough events, but the shape of the curve tells us that we would have it. Here, what we have done is we went back home and did the whole exome gene analysis, and we have looked at the data according to the molecular classification and the efficacy of the Dostarlimab. So if you look at, we could perform in 400 out of 494 patients, and when we looked at these 4 groups of molecular classification, if we start with POLE, there were only 5 patients who were POLEmut. That means that you don't see that many patients, 1% of the population which was POLEmut. And they were either receiving placebo or active therapy. None of them has progressed, none of them has died. But I'm not saying that they should not be treated with chemotherapy. What I'm saying is we need more data to see if we can spare these patients from any systemic therapy after surgery. Or, and not only systemic, but also radiation therapy. They won't need anything. Second group was the dMMR, and we have about 22% of the population which is dMMR, and we see with the exome analysis the same results, unprecedented, huge benefit in these patients. The best thing is that after 12 months we don't see any events in the patients who receive who have received Dostarlimab with chemotherapy. 60% of the patients are event-free since then, and probably we have cured some of these patients. When we come to the pMMR group, which is a very heterogeneous group, we performed their p53 analysis. So about 20% of the patients were p53 mute, while rest were p53 wild type. From the whole population, about 54%. In the p53 wild type, we saw moderate efficacy of Dostarlimab. Patients do benefit, but not as we have seen in other subgroups. But there are few events, and we have to have more events to have the more mature data. The shocking for me was to see the results of p53 mute population, where we saw enormous benefit of adding Dostarlimab with the hazard ratios reaching the same level as of dMMR population. So that was something new for us. The patients who do the worst on chemotherapy, these are the serous carcinomas, carcinosarcomas, we have seen amazing benefit in that population. And that is very important. Let's see the results of other trials as well to accumulate how we are going to differentiately treat our patients in future with one drug or the other. Thank you.